Good morning. It's almost 11 o'clock. We'll give folks some time to get in, and then we'll get started in about a minute or so. Thank you all for taking the time to join me this morning. Just give folks a few seconds more to come on in, and we'll start at the 1 minute after the hour. All right, looks like the number of attendees has kind of slowed down. So again, I just want to say thank you to everyone for joining me this morning for the first of 3 in this series talking about value-based purchasing and the different measures. So this is our first session. We'll have 2 more. Really, we're going to focus more on the claims-based measures today, but the next 2 will be on the OASIS and then the HCAHPS. My name is Charlie Breznicky. For the next 25 to 30 minutes or so, we'll go over what the claims-based purchasing, what the claims-based measures are, and then some tips that you can have to really work to improve those. I wanted to leave time at the end in case anyone has any questions, and we'll get to those as we can. So let's get right into this here. Just as a reminder on what home health value-based purchasing is. It will be going live January 1st, 2023. It will impact all Medicare certified agencies in all 50 states, DC, and US territories. CMS has estimated that the economic impact from 23 to 27 will be $3.3 billion in savings. So that's really one of the reasons that they are pushing this forward, that they're expecting to see a lot of savings there, which predominantly are expected to come from a decrease in unnecessary hospitalizations. And we'll discuss a lot of that over the next several slides and over the next half hour on ways you can identify those patients at risk and hopefully work to prevent them from going back into the hospital. Additionally, the savings will be seen from agencies that are sent to home health agencies as opposed to SNFs. As of now, the baseline year will be 2022. The final rule will come out, usually it's October. So we'll see if they did make a change back to 2019 as they'd initially said. But at this point in the proposed rule, the baseline year will be 2022. And then home health agencies will compete in their applicable size cohort, which will be either large or small based on the 2022 census. And that threshold is 60 unique beneficiaries. So if you're less than that in the 2022 census, you'll be in the small cohort, and above that, you'll be in the larger cohort. So just as a reminder as what the measures are, there's really 3 types: claims-based, OASIS-based, and HCAHPS. Today, we are really having a focus on these claims-based measures. Really, it's around acute care hospitalizations and emergency department use within the first 60 days of care. These measures account for 35% of the total performance score, so you can get a maximum of 35 points in the claims-based measures. Within this, the acute care hospitalization makes up 75% of this measure and 26.25% of the total performance score. So over a quarter of your points are potentially impacted by the acute care hospitalization score. So that's one of the reasons that we wanted to start off with this one, go through it, hopefully answer any questions you have, but also to give you some help, some tips on how you can help to identify the patients at risk and help to reduce the risk of the patients going into the hospital. You can see down there, the OASIS-based makes up another 35%. And then the last 30% of the total performance score comes from your HCAHPS measures. To score points, agencies will get either, they'll get points if they are above a certain threshold. That threshold is the minimum amount that must be met to get any points. There's the achievement threshold, which that is the median or the 50th percentile of agencies, of all agencies' performance on that measure. So this takes the average of all agencies, figures what that measure is, and you must be above that to get points. In the claims-based measures, it's actually better to be lower. So usually in the OASIS and the HCAHPS, you're above it. For today's purposes, what we'll be saying is you have to score below that achievement threshold because lower acute care hospitalization rates and lower ED rates are better. So you have to score below that achievement threshold to get any points. There's the improvement threshold also. That is the individual agency's score on a measure. So again, in the claims-based measures, scoring below that threshold will get you some points. Then there's the benchmark. The benchmark is the top 10%. So that's the top 10% agencies and how they scored in each of the measures. Again, if you're below this in acute care hospitalization or emergency department use without hospitalization, you'll get the maximum amount of points, which will be 10 points. So if you're anywhere between the achievement threshold and the benchmark, or the improvement threshold and the benchmark, you will get some points. So it's really key to know, where do you stand at this point? What is your hospitalization rate? What is your ED rate? And then how does that compare to national averages? Are you above it? If so, you're not going to get points. If you're below the national average, you're going to get some points, but it may be hard to tell now how many because we don't know the benchmark. So it's really key. Have a look at your rates, see where you are compared to national averages, and see if this is something that you need to focus on at this time. If you're well below those, you're in the less than 10% ACH rate, you're probably doing pretty well. So once you've gotten your points, agencies will get a total performance score. This is a score ranging from 1 to 100, and this is a sum of all of the points. So these are calculated using whatever's higher, the achievement or the improvement scores for each measure. So the achievements, you can get a maximum of 10 points. The improvement scores, you can get a maximum of 9 points. But you may have a higher improvement score if you scored better compared against yourself than against the average, the national average, you're going to get more points. So that allows you to get those points. So this helps out agencies that maybe are already performing better. So maybe their acute care hospitalization rate is below that, the national average. Well, if you improve even more against yourself, you're going to get some more points there. So it's really key to see where are you at now, to see, do you need to focus on this to improve against the nation or against yourself. And then every agency will get a total performance score based on the weighted sum of the performance scores. So each measure has a weight, like I'd shown a few slides ago, and that's how many points you'll get. The acute care hospitalization, again, is worth 26.25 points. And the emergency department use without hospitalization is worth 8.75 points. So potential points there, 35 total points from these two items. So let's get right into what they are. So in here, there's really two items. There's acute care hospitalization and ED use without hospitalization. So this screen here, what you can see is the numerator. So for acute care hospitalizations, it's the number of home health stays for patients who had an unplanned admission to an acute care hospital in the 60 days following the start of the home health stay. So really, this is an unplanned admission. If it's not expected, then this will count against you. However, for these planned ones, CMS will have a way to indicate in the claims if it's planned or not. The emergency department use without hospitalizations. These are the patients, the number of home health stays for patients who have a claim for outpatient ED use and no claims for acute care hospitalization in the 60 days following the home health stay. So again, patients who go to the ED but are not admitted will count into this category. However, if they go to the ED and they are admitted, they will count in the acute care hospitalization numerator. So just keep in mind, it's really important here to know when your patients are going to the ED, are they being admitted? Are they coming home, and why? And we'll talk about some of the things you'll want to have a look at in your audits as we move forward. There is a question real quick if the slides will be made available. Yes, we'll be able to make these available and get these out after this. I should have mentioned that at the beginning, but yes, these will be made available. So moving on from what the claims will be, we want to discuss the exclusions so you know which patients will not be included in this measure. So this comes straight from the CMS. The exclusions for both the acute care hospitalization and emergency department use without hospitalization are as follows. Stays that begin with a LUPA. So if your patients end up as a LUPA in their initial stay, they're going to be excluded. So we do have the 60 days from the start of care. However, if the patient's admitted to service and you only get 2 visits in and the threshold is 3 or 4, we'll say, and then the patient refuses further visits, they result in a LUPA. If they go back into the hospital within 60 days of that initial home health stay, that's not going to count against you. We're trying to continue to provide them care, but they refused, or they moved out of the service area, or were unreachable, or whatever it is, they were a LUPA, and they go back into the hospital. Well, that's not going to be, you're not going to be penalized for that. So it's really key here, having an understanding of what's excluded and what's not. So your LUPAs, yes, we want to know why they're a LUPA, what can we do to prevent them? But these will not be the patients that count against you in the acute care hospitalization measure. Additionally, patients receiving service from multiple agencies during that first 60 days. So if you get a referral, a patient had home health 30 days ago, and now they're coming to your agency because they moved from one area into another, to your service area, and they go into that hospital, these would be excluded as well. So really it's important. We want to keep folks out of the hospital. However, if you're seeing patients that are coming from one agency to yours, they will not count against you if they go back into the hospital. And then also patients who are not continuously enrolled in Medicare for the 6 months prior to the home health stay, or for the 60 days following the start of the home health stay, or until death. So if a patient is newly enrolled in Medicare, 1 month before they come to you, they will be excluded from this measure. So again, really important to know what is the payer source, and as much as you can, knowing how long they have had Medicare as their primary payer. So not that we need to track all this, because we're not going to treat the patients differently, but just so you know who are the patients that will be excluded from this measure. These are the lists here provided by CMS. So when we get into this, now that we know the patient's excluded, we want to know those that may be at higher risk for hospitalization. So studies have shown that the following factors increase a patient's risk for hospitalization: being male, patients with multiple medications, which can lead to med confusion, not being able to afford meds. Maybe they have the same med in the home, but they don't realize that it's 2 different names, and they take a double dose and end up in the hospital. Patients with a decreased functional ability. This may have them at an increased risk of falls. They may not be able to care for themselves as well. So they're at increased risk for hospitalization as well. Patients who are Black may be at increased risk for hospitalization, and those with a history of hospitalizations. This one is right from one of the OASIS items, that patients who go to the hospital often, they're probably going to continue that pattern. So if they've been in the hospital 3 times in the past 6 months, that pattern may continue, and we want to explore why. Why do they keep going back? What can we do to work to prevent them from not going back there again? And then patients who have an increased level of symptoms of depression. Maybe if they're more depressed, they're unlikely to take their meds, possibly self-harm. So we really want to have a look at those. How are we addressing the symptoms? But how are we identifying those? Making sure that staff know what the symptoms of depression are, and then getting the appropriate resources in place to address those. Along with those, there are some diagnoses that increase the risk of hospitalization. So heart disease, this is one that can be that's a chronic illness. Patients with this are at increased risk of hospitalizations, often for the reasons above. They may be on multiple medications and they're not sure how to take those. They may be in the hospital in and out often. So all of that increases the risk for for going back. Patients with COPD, having an inability to breathe, lack of oxygen maybe, all of these may impact the patient. So if you have patients with heart disease, COPD, you really want to have a look at what are the pathways, what are you doing to try to prevent those patients from going back to the hospital. Patients with skin wounds as well have been seen to be at increased risk of hospitalization, possibly because they're at increased risk of infection. If they're not able to perform the wound care, who is? Are they able to do it? Are they aware of the signs of infection and when to seek care? And then the patients who have history of UTIs. Again, infection can pose that risk, and it can come on pretty quickly in an elderly population, and they may not seek care timely to prevent them from being treated at home, so they may end up in the hospital. So once we've identified our high-risk patients, there are some things that we want to do to make sure that we're trying to keep them out of the hospital. First of all is making sure everyone on the team's aware of this. Not just the number as to the patient's risk as scored an 8 out of 10, so they're at risk, but what are these specific reasons that they're at risk of hospitalization for? Is it because of meds? Is it because of a wound with a potential infection? Because that may impact where they're focusing. So if someone has multiple medications, we want to make sure the staff know that they are addressing this every time that they're going in. Asking simply, did you take your medications, making sure that we do an accurate med reconciliation. If it's more for wounds, asking the patient to have a look at that wound, any signs of infection, temperature, increased pain at that site. But make sure that staff know what are these specific factors that put the patients at risk for hospitalization. Making that easily available within the EMR so that it can be seen, so staff can intervene and at least be aware of this and communicate that out to others. Additionally, utilizing telehealth or remote patient monitoring can really help to address these high-risk patients. Now, telehealth, having the equipment in the home as to do video calls and remote vital signs, that is great if you're able to do that. However, we do understand that that's not possible for everyone. But there are other ways to do remote patient monitoring. It could be a follow-up call asking about some key questions. You're short of breath, any questions about meds, how is your wound, is there any increased pain there? This can be done on the days that patients are not having visits made to try to identify symptoms of potential areas of concern earlier on. Once we do that, we want to intervene, and it may be having a triage nurse making a visit on that night to evaluate a wound, or making sure the patient's on a schedule for the next day, or even a phone call again later on in the day after they've taken their meds because their blood pressure was high. So we've identified our high-risk patients. We then want to monitor them and address any concerns timely. Additionally, visits and how to utilize them are really a key item here. In the VBP model, successful agents, CMS had found that successful agencies tended to front load the visits for nursing and therapy, and this helped to reduce the chances of unplanned hospitalizations. So putting more visits up front, just more eyes on, in addition, staggering the visits. So you're not sending in nurse, PT, OT all on the same day. You're having a nurse on a Monday, PT on a Tuesday, OT on a Wednesday, and then repeating that with maybe some phone calls on a weekend to have a touch point every day for the first maybe 2 to 3 weeks of that the patient is on service. This can help reduce those unplanned hospitalizations. And additionally, making sure you have plans in place for strong transitions of care. So this is, how do you get the information that you need up front to know that the patient is going to need, one, the right disciplines in there, so that the patient's at risk for falls. You want to know that as soon as possible to make sure that the nurse is aware of it, but also to get the therapists involved, ideally on day 2, to help to put some plans in place to reduce a risk of falls. Then additionally with that, coordinating the visits over the first 2 weeks of service. This may be the role of the clinical manager, having a look at the schedule for that patient, seeing who is seeing them when. Additionally with the staff, providing like a summary at the end of each week to say, what are the areas of risk and what do we need to focus on for the next week to try to make sure the patient is safe and able to stay at home. And then once changes are seen, if there's a change to the visit frequency, maybe the patient refused a visit, we want to make sure everyone else on the team's aware of this and what the plan is to make up the visit. Maybe they refuse to the nurse for a visit on a Thursday, but we know the PT is going to go the next day. The nurse and the PT should talk. What was the nurse planning to review? What does the therapist have to report back to the nurse on any of the findings in case a visit must be made that day as well? And if the visit frequencies have to be dropped down or increased, making sure everyone's aware of that so they can cover and kind of shift their schedules as need be. All of these are items that help us to use the limited resources of the staff in the field, making the visits, using our visits in the most appropriate manner. So we've had our visits, we've identified our high-risk patients, we're putting plans in place, we're using our visits in the most effective way. No matter what, we're going to still find abnormal findings. So how are they handled? If someone's out there and they see something abnormal, maybe increased blood pressure, we definitely want to call the physician, make them aware of it, but have a look at the patient's schedule to see who's going to see them the next day. Give them an update, make sure that they're aware of this, and the patient followed up in any instructions that we gave them. Keeping them aware of this, and then they should give that feedback to the nurse in case additional follow-up is still needed. And then reinforcing to patients and to caregivers when to call the agency and when to seek emergent care. This is really a key thing that a lot of patients and caregivers tend to just, maybe they forget, maybe they're not sure, but they'll go to the ER before they call the agency. So reinforcing this from everyone as often as you can. We have staff available 24 hours. If there's any questions, call us first. Here are some reasons that you should just go right to the ER, but for others, call us. We'll get someone out, we'll help you out. We'll do what we can to try to keep you at home so you don't need to go into the emergency room. Additionally, when calling to the physicians, encourage them to evaluate the patient in the office. So this is really in the phrasing of how, rather than say, how do you want to handle this? Say, when can you see him in the office? Just opening up that, putting that in their heads to think about, hey, let's see him. Here's what home health, what we can do to keep the patient out of the ED. Can you see him in your office? We'll follow up with them the following day or later on in this evening, if that's possible as well. Additionally, make sure everyone on the team's aware of this. Put it in the note, share it if you have regular staff meetings or a phone call even. Make sure everyone involved in the patient's care is aware of these abnormal findings and what the next steps are going to be. Scheduling a revisit for the following day, or at least coordinating with whoever is going to go the next day so they're aware and they know how to follow up. And then if we saw the patient in the morning, we saw some abnormal signs and symptoms, calling them back later in the day or even the following day if we saw them in the afternoon to check up on them. One, this can help to reduce their risk for hospitalization, see if they need another visit. But two, it helps with the customer service, showing them and demonstrating that we're really invested. We want them to stay out of the hospital and we want to meet their needs. So providing that follow-up can really help in multiple ways. Then here also, when the patients do call, so they have some symptoms, maybe they're confused about a med, but when they call the agency, they want their concern addressed, whatever it is. So it's really key that we have someone available, we get back to them, making sure that we are addressing their needs and then asking them, what else can we do for you? One, it helps with customer service, but also they may think that, oh yeah, I had a question about this, or I'm going to see my doctor, should I bring up anything else? Make sure that we're addressing their needs when they call. And then make sure the patient and their family understands how to call the agency after hours and on weekends. For the case managers, if they're going to be off for an extended amount of time, they're taking a vacation, make sure patients are aware of this so that they know someone else will be there to see them, but you gave them handoff. They're aware of their case and any updates. This can help put the patients at ease, but then they know when they're calling in that their case manager is not going to be there, but the clinical manager or whomever it is should be able to answer their questions. And then the last part, if a patient calls the agency, we asked them to, we said, call us first. But if no one answers, they may just go to the ER, and that's a lost opportunity because the next time they may not even call. They may just go to the ER because they did not get the help that they needed. So it's really key. What happens when someone calls in? It's sometimes you can just try this out from just a random number. Call into the office. What happens? Ask for help. Do you get routed to the right department? This can help to reduce hospitalizations, but then also help with the customer service as well. So no matter what we've done, we identified our high-risk patients. We put plans in place. We used our visits the most effective way. Patients called us, but they still went into the hospital. It's going to happen. We want to know why. So we do some audits. Really, we're having a look at, were there abnormal symptoms present, yes or no? And if so, what was the follow-up? Was it appropriate? What could we do in a different way? Is it a phone call? Is it making sure a visit is made the next day? Is it working with the physician to try to keep the patient out of the hospital? All this allows us to grow and to continue to fine-tune our hospitalization prevention program. So having a look at these audits, sharing it with staff, making sure they know about this, and engaging them to develop plans to reduce hospitalizations can help. Then also have a look at, was the hospitalization risk accurate at start of care? Do staff know how to identify that risk? And once they do, how is that information shared? So all these are some tips that you can use to reduce hospitalizations. Really in your audits, doing these every month, summarizing the data, sharing it out with staff, going back and engaging them to develop plans to further prevent hospitalization can help to bring down that acute care hospitalization rate. I know that was a lot of information in a short amount of time. My contact information is up here. Feel free to reach out if you have any questions, if we don't get to any of those that are being asked. So we do have some in here. The first question is, looks like they're both about the LUPAs. Does the LUPA exclusion include if they were a LUPA due to the ACH? If we do a start of care, patient hospitalized same day or the next day, then goes to SNF and do not get resumed by home health within the episode. That's a great question. And according to what CMS said was those that begin as a LUPA would be excluded. They may have further clarification on this in future trainings, but at this point, I would think if they're a LUPA because of an acute care hospitalization, they would be excluded because they said those that result in a LUPA are going to be excluded. And then the next one, similar, if a patient is admitted to the hospital after 2 visits and the first 30-day billing is a LUPA, it does not count in the ACH rate. That's what it sounded like according to CMS. They said those home health stays that result in a LUPA would not count. And we'll go right back to that slide there. This was right from CMS. So those that begin with a LUPA claim, so if it's a LUPA in that first 30 days, I would think that they would be excluded there. So again, you know, CMS may provide some additional information, but at this time, they just said those that begin with a LUPA are going to be excluded. So hopefully that answered the questions that you guys had. Again, if there is anything that was not clear or you want to discuss some more specific questions, I'm happy to help out. Feel free to reach out. My email is on here. And thank you again for taking the time to attend this morning. Our next two sessions, look for some emails that come out on those over the next several weeks. Thank you again. Hope you have a great day.